Okay, let's open the floor to questions from you. If you can give us your name and your, yep, right there. And there's a microphone coming up. If you can hold on just until I give you the microphone. So our webcast audience can hear your question.
Dixon Ogwang from the Embassy of Uganda in Washington, D.C. This has been a very interesting discussion and understanding of how mobile technology can be used to improve healthcare. My question goes to the panel in regard to the local person in Africa. Deep down in the village, how do you envision the mobile technology? How do you think it's going to affect them positively? How are we going to reach that local person in the village, rural community? My desire has been here waiting to hear how we're going to really benefit the local man with the invention of this new innovation. Thank you.
Great question. Anyone want to respond to that?
I'll go first.
Okay, yeah, you go first.
I like your question. In Nigeria, we think no matter where you are in the country, most people now have access to a mobile phone, right? So that's good. I'll give you an example of what we're trying to do now. We noticed that we have more mortality for women and children in rural areas compared to urban areas. And that was why we focused our programs on working in rural areas. But we need to actually generate demand, and you need to empower women with education about the key ANC messages for maternal health and for child health. So what we are doing now is working on an alliance with Mama, which is basically using the mobile phones to give content to new and expectant mothers. So that's one. And I think that platform also serves to give content on so many other key messages for health. I mean, people get text messages on marketing for different things by their mobile phones. The second thing we've done in Nigeria is we launched a program last year called Money for My Phone. So we're disbursing cash to women for the cash transfer program through the mobile phone. So the woman qualifies for like maybe $30 for having 4 NCV seats, kids by delivery and immunization. She's verified that she's completed the program, and she gets a text message which she can go to a mobile agent and cash down rather than coming to get a cash disbursement. So we are reaching women in rural areas to the mobile phone for that. And I think the third is, okay, two.
Well, I'll go off of that. So with the cash disbursements to mothers so there is a protocol that WHO has endorsed that is able to approve outcomes for mothers, right, for expectant mothers. And that is 4 ANC visits and an attended birth. And so what Dr. Ocean is picking up on is that, and the program for cash transfer, conditional cash transfer, is that if women complete that protocol, that they will have money given to them. And so what is the documentation for that care? And so we're looking at how we can work into that program to provide that documentation for that care. And so when you come in and you have a visit and it's documented through this electronic system, then it automatically generates a report of who has that conditional cash transfer, is it eligible for that conditional cash transfer. And then possibly through our data capture. So as a caregiver is working with a patient, right? So a mother comes in and a caregiver is there with the tablet and they're documenting care as they're sitting in front of them. And so when you document care and you say, what visit is this? And they say visit 2, a message can pop up and say, let the person know that if they complete 2 more visits and a skilled birth, they will have the opportunity to have cash transfer. So this guides the caregiver in their interaction. Now, that's for participation in a certain program, but you could also have those messages pop up for any number of things. Let the woman know that her blood pressure is high or her iron is low and that she needs to be particularly careful about this. So we have this infrastructure in place. We already have some clinical support for that interaction between the caregiver and the patient embedded in our system, but there's even more and more that we can put on top of that. So when you talk about, how is this benefiting somebody, who's the people in the village, the people on the ground, the normal people walking around in the country, this is giving better care to them at the point of care. It's allowing us to have better outreach to them and put in better programs for them.
So thanks, and so let me first start by saying that at least half of the health centers that we're working with or the communities that we're working in are exactly what you've described. There are places that are not on the national power grid. The question may come up, so how do we provide power for the tablets? We have portable solar power chargers. So they're in exactly the place that you've just described. So how do you get enhanced care to that, woman in that community? So let me give you a very quick example, and this is real. In one of the states that we're working, Ondo State, they have this program called the ABA Safe Motherhood Program. In that program, they have health rangers that go out to the communities and perform outreach. They talk, figure out how they're doing, how the baby is doing, try to bring them into the healthcare system. Now, these people go blind. They go without the history. And so if you're able to arm that person with the patient's history, first of all, you are able to make that a much smarter visit because, if there's 10 people on your list, you can say, well, these 3 people are compliant with everything and they've been coming in. So scratch that. You focus on these people and, this person, make sure that you bring her to the nearest specialist hospital because she's high risk. Or that person, right, this is her history, this is what you need to counsel her on. So you make that interaction a much higher value interaction in that community that you've described. And those are the communities that we're working, as Dr. Oshin said. The focus is on the rural communities because, the urban communities have their issues, but there's a lot of resources being devoted. There's not nearly enough being devoted to the rural the rural areas.
Along the wall. Gentleman over there.
Hi, I'm Arthur Allen from Politico. It's interesting that Brookings invited people from this one specific project. What I hear from people who work introducing technology in Africa is that various countries are littered with great sounding projects that were abandoned after a few years. I was wondering if the participants could talk about what kinds of, it sounds like a wonderful project. I was wondering, how is it being sustained? What's the plan for sustaining it? How long is it being funded by Qualcomm? And then what's the plan after that ends?
You want to take that one?
Yeah. Okay, so I'll start. I think the difference with this project is it really wasn't donor-driven or initiated. It was in response to a government effort or initiative to improve health outcomes. So we see it more as a partnership, as a collaboration, one. The second is there's a footprint in the country. In Nigeria, we've done analysis about different projects that have come in. Like you said, many of them basically just died out. One, because they did not really engage the right authorities. And 2, there was no clear sense of where this was going to. So there's a vision that we want to improve health outcomes, not to save 1 million lives. We have a national committee of practice, actually, that is now embedded in the Ministry of Health. So there's an ongoing platform to continue the discussions. Where we are now is really just analyzing the results from this pilot phase to inform decision makers in the next political cycle, because that needs to go with evidence of efficiency and then value for money, where we can now begin to get it entrenched into having a budget line in the Ministry of Health to fund a continuous deployment of the program. And I think most programs don't go through that kind of rigorous system to ensure that it becomes government-owned and it's within the government's priorities. So I think that's where this is different. But Nigeria is a big country, and it is very unlikely that the government would alone fund a whole national scale-up, which is why the earlier we can share our results and seek for partnerships and collaborations based on people's interests to drive specific sections, then we can begin to see how everybody's contribution adds to that big scale-up plan. So what we envision is to map out what scale will look like, what it will cost, and then now see how we can begin to get different elements to fund different sections.
So I'd like to come at that from 2 different angles. One is from the public-private partnership angle. And the second angle that I'm going to come at it is the social impact investment. So this has been successful because there's been a very strong public-private partnership involved in this. And the government has institutional programs and institutional knowledge. The private sector has the discipline and the execution experience and competence to drive those through the public institutional systems. And so, and of course, with the funding, we're able to do that and then prove the outcomes. And so that, and when you prove the outcomes, then, sometimes I get this question in Nigeria and I, come back to people and say, well, I remember a time where you had to stand for 3 hours to cash a check. Now you can pick up a basic phone and transfer money. If somebody ever told you to drop that system and go back to 3 hours, you would be up in arms. And so if we're able to prove program by program that these outcomes, the only way to these outcomes is through this system, then the sustainability is embedded in that value proposition, right? And so with social impact investment, Instrad, for example, is a for-profit company that's working within a social impact space that Qualcomm is funding. It is incumbent on me, for my company's survival, to prove those outcomes and to identify the sources of sustainable funding to keep those outcomes going. Otherwise, my company goes out of business.
And I'll just say, from a IT company who's implementing systems, throughout the world, in first world healthcare and then in third world, is to say that we are employing industry techniques in this. And so when we take a look at this, we're taking a look at, not from a research or program or other things, we're looking at it from an operational point of view. And so when we put a system in place, we're looking at adoption, data quality, data dashboards, these types of things. Not necessarily from the clinical point of view will follow, but we want to say implementation, adoption, operationally, is this system getting us what we want? And I think that's been something that's very unique. We want to see that people are submitting their data, on time, and it's complete, and how many of the fields are filled out. And then we want to close that feedback loop back to the individuals who are taking that data. And then we want to set up the quality of that data. So we have very clear methodologies that we are putting into place, and that we continue to challenge to see what kind of efficiencies we can gain from this. So where's the efficiencies we can gain in technology? Are there better things coming on the market? The tablets are commoditized. They're getting smaller. They're getting cheaper. Is there something else that's becoming even better to do this with? The solar power, overcoming the barriers. How do we make this more accessible to people? The methodologies of adoption or training or data dashboards or feedback. Can we use Salesforce? Can we use other tools and incorporate them in so that we're not using people, that this is all automated? And so that feedback loop is automated. And so part of scale is, this initial capital investment and the people and the training and getting people to do the adoption. But eventually you're going to get to a steady state of, support. What's this cost to just keep it running? And we're trying to keep driving that down. What are the tools that we can bring in? What are the methodologies to make this sustainability less and less expensive?
Sorry, just one quick data point on that, on sustainability. One state government that we're working with has made a commitment that they're going to scale this across all the health centers in their state, and they're now working on how they're going to fund it. And they're talking, in that state, they have about 550 health facilities. It's not going to be all at the same time. It might be in chunks of 100 or 200, but they've made that commitment because they see this as a critical imperative to the vision of their healthcare delivery, and the near-term vision of their healthcare delivery, by the way.
Okay, on the aisle there.
I'll go. Raylyn Campbell with the Mobile Alliance for Maternal Action, MAMA. I kind of wanted to piggyback on that because my question was about cost savings. Obviously, MAMA is about the demand generation, making sure women go to their for and neonatal visits and vaccinations and different practices and behavior across the continuum of care. But at the same side, listening to the Ebola conversation, MAMA can also be about demand mitigation and making sure that practices that can be adopted at the home, knowledge that can be acquired through mobile messaging can help bring down the number of visits and the burden on the healthcare workers at the front line. And I'm just curious, you were kind of alluding to the cost savings, but how each of you look at models for saving costs over the lifetime of the project and how that helps government save costs in other areas in education of the healthcare workers and have this mobile approaches be more cost-effective ways of getting information to people and saving costs in other sides of government budgets maybe.
Let me relay an experience we had. When we started the cash transfer program in Nigeria, there was a requirement for political visibility so that people could see that women were actually getting cash payments. So we would convene what we call cash payout days, organize tents and chairs and refreshments. Women would come down, sit down, be verified, and be paid. And when the program grew to its 18th stage, it was becoming a huge amount of money just to fund the system to pay the cash to the women. And that's why we moved into the mobile platform. Now, to move into the mobile cash transfer payments, we had to go through a process of convincing the directors, the audit people that, look, this is a more viable option. So what we did was we got in touch with the banks and the telcos, and we basically worked out the transactional cost for a mobile payment versus how much it costs to convene a physical cash disbursement day. And the value for money was clear. We were saving up to 6% on overhead costs by going to the mobile platform. So I think what we need to do for MCH and Ebola and other cases is to really begin to work out the maths. So what do you currently expend on your current system as it is? And what would you expend if you're using a mobile solution or an approach? And once you have enough data points to put forth the policymakers, then it's a clear case and it's a no-brainer for there to be that shift to adopt. But yes, and there's no.
So it's been a while. I'm a little bit out of touch. Okay. Yes. Yeah.
Yes, also on the aisle, there's a question.
Yeah, okay.
Hi, I am Amaka from a Nigerian think tank called the Center for Public Policy.
Oh, okay. Gotcha.
All alternatives. So it seems like you guys are all alluding to a very specific VECNA mobile platform that has been rolled out in Nigeria, and I understand it's called Clinipac. And I wasn't previously aware of it, so I'd really appreciate sort of more details about exactly who's using it. Is it just midwives? Where is it being used? Is it in community centers? Is it in, government clinics? Is it in private clinics? Where exactly is the data going? Because somebody alluded to the idea of maybe the Ministry of Health is collecting data and using it. Is it going to the Ministry of Health? Is it going to state governments, local governments? Where exactly is it going, and how is it being used? So it's kind of, especially in Nigeria, since most of you have that experience in Nigeria, I'd really like to learn more specifics. Thank you. Oh, and how is it being funded currently? I don't think we got an answer to that question. Thanks.
So it's being funded by Qualcomm. Okay. Thank you. And right now, in Nigeria, we're working in, since you want us to be specific, we're working in 4 states, Anambra, Kano, Ondo State, and the Federal Capital Territory. We're working all in yes, 3 of the states.
We're working. Things I found most interesting about when we saw the annexation of
someone talk with our audio people and tell them to take care of this problem.
Russia has a very large stake in Ukrainian arms developments, and for example, the number of transport planes.
That's probably a more interesting. I want to listen to that as well.
was also that Ukrainian industries provide.
So since I have the floor, for the people on the live webcast, there is an audio interference from a different session that's going on that I believe has just been addressed. So we'll carry on. So we're working in these 4 states. We're working with the SURE-P, the Subsidy Reinvestment Act, who has a maternal and child health program. In about half of our facilities, we're working with the National Primary Healthcare Development Agencies. In the other half, they have the Midwife Services Scheme. In the other half, we're working with the Ondo State Ministry of Health. The data that we're capturing currently goes to the stakeholders. We send it to the SURE-P leaders, the NPHCDA leaders. We send it to the Ondo State Ministry of Health. We're working, by the way, and then we send it also back to the facilities to populate the reports that they then submit up to the National Health Management Information System, which we're currently working to overcome by directly reporting our data from Clinipac into the National Health Management Information System. You asked quite a few questions. I'm not sure if I've addressed all of them.
I can say a little bit about Clinipac. So the Clinipac system that we're using in Nigeria is based off of an open source platform called ODK. And specifically, we're using a modification called ComCare, which was put together by another group called Damagi. And there are a lot of really fabulous tools out there. And so what we try to do as Vecna Cares, the nonprofit arm of Vecna, is to consolidate these tools into one larger infrastructure or ecosystem. And what we're doing with that is taking some of the more user-friendly or the ones that fit the situations in which we're implementing and connect them into a larger infrastructure. And so we have a clinical database that the information from all of the clinics feeds into. So we're creating something of a master patient index. And then we're creating, for each of those, the documents of each of their interactions with the healthcare system. And so that's what feeds the aggregate data that gets pushed over to what OK was referred to as the DHIS2 system, which is the national reporting system. So what that does, it takes patient information and aggregates it into just numbers and totals and pushes it over to that system is what we're achieving this year, instead of having to have that reporting system from the clinics. And then we also we're actively generating data dashboards that we then distribute to our stakeholders. And we're refining those data dashboards, and that's what I was talking about with the automation of this. And I didn't get to address one of the things that you had brought up, which is also how do we drive down the cost efficiencies. What we really want to do is see how we're using the resources we have right now and how can we use them more efficiently. And so what we're doing is taking some of the, as Dr. Ocean was saying, of the change management and working together with policy, et cetera. And OK was saying that this is not my job. We're actually working together to make it people's jobs, right? So what is the medical records officer doing at the district level now? Well, now we have to train that person. And so, yes, there may be some investment in training and human capacity building, but we're actually working that into a system that's already there, that's already funded, that's already moving forward. So we're looking for opportunities like that where we can, again, set up this automation of this reporting and push it back to people, allow them to make better decisions with their resources. And this could be as far as how many visits do we get to a center and is it well staffed? Or are there too many people for the visits that they have? And so to manage their human resources better. This could be like what OK referred to, immunizations that are sent to various locations. If you can say, my refrigerator is down, don't send me immunizations, or vaccines, I'm sorry, then that's going to save a lot of vaccines from going bad. If you can say, we're up and running and we're having a lot of people coming in, then we can send you more. So having that communication infrastructure put into place is hopefully going to be something that we can show the impact of efficiency gains with the resources that are resident in the system.
Especially when you're now able to plan ahead.
Yeah, I think we have time just for one last question. There's this lady on the aisle right there. There's a microphone coming up right behind you.
Good morning, ladies and gentlemen. My name is Rosemary Segero. I'm president of an organization called Hope for Tomorrow. We are based here in Washington, D.C., and in the rural areas of Kenya, Western Kenya, in Kakamega. We just started a mobile applications working with the government, as I commend you very much for what you said about human factor. There is always a very big barrier when it comes to government, regulatory, and licensing of frequencies. We taken almost 6 months looking at our frequency to apply education, healthcare, and entrepreneurship of rural areas of Kenya. So what advantages or disadvantage did you get by getting the frequency and looking at what Deborah has just said, communication? We have many organizations doing what you are doing, what I'm doing, but they don't know what each other is doing. So everybody's duplicating everything, don't know. So how do we get this information, getting a conference or an event in Africa there, in Kenya, where I come from, and call all these people to come and listen to what you are doing? The government is another headache, the people, and so we need all this collaboration and information to show what we are doing to the people, especially the rural areas who need more attention than the urban area. How do we collaborate and how do we come together to get to work together with your applications and my applications? Thank you.
Well, coming to this event is the first step on collaboration, so appreciate that.
We are also working in Kenya. And so I understand what it is that you're saying. And okay, because we do a lot of work in healthcare here in the United States, there are some pitfalls that we hope you will not fall into. And one of those pitfalls that we're suffering a lot from right now in the United States is interoperability. So the ability to exchange health information across facilities and states or whatever. And one of the problems with that is that we have no standards, right? So we have no standards for the data, for how to transmit that data, of how that data is being stored. These are issues that will be popping up with you. And so if you have, it is not an intention to limit the innovation of technology to end any of these successful programs that you have had. You should definitely continue to support them, and the tools that are working for you should continue to work for you. So it's not in limiting the amount of players in this space, but it's giving them a framework in which they can contribute to a health information ecosystem. And so if you have a mobile health program that is coming in, you need to understand what issue are they addressing, and how does that what piece is that playing into your larger system? So if, for example, we're addressing maternal child health within this subset of clinics, and we're feeding up into a larger system, then if we're setting up a master patient index or something that's patient-centric, we should be conforming to a standard of how that information gets transmitted back and forth and saved. And so when you have another group that's doing that same thing, they build it to that standard. And then we're able to combine those. So if you have something in the north or something in the south or southwest, then those can eventually come back all together. And so when you think about policies within your countries, don't think about it as saying you are an admitted vendor or an admitted technology or admitted this, because you may be hampering innovation. But instead say you must be able to transmit your data, share your data, conform to these standards, and then mandate that we all, contribute to the DHIS too. That if you set up or adopt a national patient index or just individuals, that can be generalizable enough that people can feed into that. And then if there's specific program data that they're using on the ground in those areas, that those can be within their own format, but then the other data can be freely shared among all of these programs. So from a technical point of view, sorry if that was a little too deep for you, but or too technical into the weeds there. But we are very anxious to see the e-health policies become more of a standards policy so that we can avoid a lot of the headaches that will continue to plague the United States and first world healthcare for decades to come.
Well, it's been great to get the perspective from the front lines. Those of you who want more information, OK has a demonstration on a laptop, so you can come up afterwards and see what they're actually doing. But I want to thank Dr. Ocean, OK, and Debbie. It's a great innovation that each of you are doing, and we really appreciate your coming here to share your thoughts. So thank you very much.
Thank you.